I just wanted people to know that we are really in a new age of targeted treatments for not just Fragile X, but for a variety of neurodevelopmental problems. All mainly talk about the Fragile X and autism treatment studies we're doing, but there are many other treatment studies taking place around the country: tuberous sclerosis, Rett syndrome, even Down syndrome, and we hope to have this GABA-A inverse agonist here in the future for Down syndrome. But this new age of targeted treatments has really come about because of the advances in our understanding of the molecular biological abnormalities of these disorders and the neurochemical changes that occur because of the genetic mutations or problems that we see in these disorders. We'll talk a little bit about GABA and glutamate imbalances, which is common in Fragile X syndrome and in autism. But there's other common pathways across a variety of disorders that we won't have time to talk about tonight. I also want to mention that there are commonalities in the dysfunctional brain systems, particularly in autism and Fragile X, but also for other types of intellectual disability. Problems with synapse formation and synaptic plasticity, this GABA glutamate balance, problems with brain connectivity, mitochondrial dysfunction. And one of the reasons why there's such an overlap between Fragile X and autism is because the protein that's missing in Fragile X syndrome controls many of the genes, or the translation of those messages into their respective proteins. And many of these genes, when mutated themselves, can cause autism. So Fragile X, or FMRP, the Fragile X protein, is the main controller of just a whole variety of proteins working at the synapse. I want to point out in Fragile X syndrome that we're talking about individuals with the full mutation. That means more than 200 CGG repeats with little or no message, little or no protein. But also we do a lot of research in individuals who have the pre-mutation or are carriers of Fragile X that have excess message. We're finding that some of these individuals have low protein, so we think that actually some of the targeted treatments for pre-mutation carriers, particularly for the boys that have an autism spectrum disorder related to the pre-mutation, may have a similar good response to some of the targeted treatments. Now, we talked a little bit about FMRP. This is an RNA binding protein that transports messenger RNAs to the synapse, so it's taking a variety of other gene messages down to the synapse, and there it regulates protein translation for proteins that are very important for synaptic plasticity. And one of the ones that we're going to talk about is the mGluR5 system. It stands for metabotropic glutamate receptor 5 system, and this is a system that leads to long-term depression, and Fragile X is the main inhibitor of this system by preventing the messenger RNAs into their respective proteins that pulls in the AMPA receptors. So because the mGluR5 system is upregulated, causing enhanced long-term depression, we are treating with mGluR5 antagonists. So this is a targeted treatment for Fragile X. We tried Phenibom in a small study. That company actually went bankrupt related to another medication. This was the Neuropharm company. But Roche and Novartis are two very large drug companies. Roche has an mGluR5 antagonist named RO4917523. And Novartis has an mGluR5 antagonist named AFQ056. And we're studying the Roche one in kids 16 and older with Fragile X syndrome. And the Novartis one we're studying in adolescents who are 12 and older, and also in adult individuals with Fragile X syndrome. There's a new one coming up with Seaside Therapeutics that hopefully will be doing Fragile X trials soon, and there are probably other companies that will be developing mGluR5 antagonists. So the preliminary data, at least in the Novartis European trial, was positive, particularly for those individuals that had a full mutation that was fully methylated. They had the best response. I want to point out that the mGluR5 antagonist MPEP has also been helpful for the autism mouse model. And so I talked to both Novartis and Roche about doing clinical trials in idiopathic autism, and I think that will happen in the future. They just want to see if they can demonstrate efficacy first in Fragile X. So we're very excited that hopefully we can talk them into treatment trials in autism without Fragile X syndrome. So it was helpful in the autism mouse model by decreasing this repetitive self-grooming behavior, and this is from Jackie Crawley's lab at NIH, and Jackie is a new researcher here. I also want to mention Baclofen, which is a GABA B agonist. Now the GABA system is very downregulated in Fragile X syndrome. And it's thought that Baclofen, which works presynaptically, it actually lowers the level of glutamate at the synapse, and that downregulates the mGluR5 system, and it lowers the excessive levels of protein that are produced in Fragile X syndrome. So Baclofen is a medication that we're trying in both Fragile X syndrome, and we also have a treatment trial in idiopathic autism because it was very helpful for idiopathic autism in an open trial. So we're studying this in both Fragile X syndrome and in autism for individuals 5 and older and into adulthood, so into the 20s. I want to point out here that there are, here's where Baclofen works with the GABA B. Here's where the mGluR5 antagonists work here. There are also other medications. For instance, we're just completing a minocycline trial because there's too much of this protein, MMP9, and minocycline also slows down the translation of other messages into their proteins, and so it lowers protein production, and that's one of the reasons why it's thought to be helpful in Fragile X. Very helpful for the Fragile X mouse, as I'll show you. We are also studying ganaxolone. The GABA A system is downregulated in Fragile X, and so we want to upregulate it with ganaxolone, and we're starting a trial that we're already making the medication for in Fragile X syndrome. I want to point out that minocycline, again, there's a study going on at NIH looking at minocycline in autism. It was very helpful in an open trial in Toronto by Carlo Parabello, and we're just completing a controlled trial that Dr. Mary J. Lee has coordinated, one of our developmental and behavioral pediatric fellows. Sometimes it can cause graying of the teeth or nails, but we think it's going to show some efficacy. So we're excited about the analysis of that data coming next month. So as I mentioned, we're doing a controlled trial of ganaxolone funded by the Department of Defense for Fragile X syndrome ages 6 to 17. We have also found that early use of sertraline, which is Zoloft, it's an SSRI, has been helpful for stimulating both receptive and expressive language in a review that we did on all of the young patients treated here clinically with this medication. And so we've just been funded by Maternal Child Health to look at a controlled trial of sertraline in Fragile X syndrome for kids ages 2 to 6. So our preliminary data suggests that it boosts language, receptive and expressive, and it improves anxiety. I want to point out that another agent that increases serotonin in young children, this is Buspirone, we're doing a controlled trial of Buspirone in autism between ages 2 and 4, and the PI of this is Dr. Robin Hansen. And I want to say that we're combining our targeted treatments with educational programs. CogMed is something that we're getting some preliminary data on, iPad, and even a literacy program, particularly when individuals are on some of these targeted treatments. And then this is my last slide, just thanking our clinical trials, a team of people. Norm Brulé is our director of clinical trials. Michelle Ono has helped a lot with that, and many coordinators, and I'm sure I'm forgetting stuff. And many people, but we have a really more extensive team. Also, David Hessel and Susan Rivera each have whole laboratories that are working on Fragile X, and Tony Simon is also working on Fragile X too, but you will hear from him later. And then we have a number of international collaborators. So thank you very much, and I think I have not gone over. Yes.
Well, from a layperson's standpoint, how important is the atmosphere, the environment that the person is in? Happiness, depression, do those things matter?
Oh, yes, yes. Both the environment and the psychological status of the patient matters a lot. So enriched environments and lots of interventions, particularly from an educational therapy viewpoint, also helps to strengthen synaptic connections. So we always want to optimize that and get the best kind of therapies and treatments, speech and language, OT, motor intervention, etc. Also, we're lucky that most patients with Fragile X are very happy. It's rare to see someone with Fragile X syndrome that's depressed, but almost all of them are very anxious. So, in middle childhood, we're often using SSRIs and medications to treat anxiety. And moodiness and mood instability is very common. We use a lot of atypical antipsychotics like risperidone or Abilify, aripiprazole. Preferably in low doses to treat some of that mood instability and outbursts and aggression. So the targeted treatment trials are often on top of a baseline group of medication, but sometimes they're not, they may be too young or haven't been tried on other medications when they get enrolled in a targeted treatment trial. So either way, it seems to work.
Thank you. Anybody else? Randi,
So, yeah.
Can I ask a question? Can you comment on, you can pick one of these questions, either say more about how what we learned in Fragile X is going to help us understand autism, or two, how understanding Fragile X in young children has actually allowed us to understand about neurodegenerative disorders as well.
Yes, and both of those statements are very true. In other words, because there's such a similarity between Fragile X and autism in terms of the neurobiological overlap, mainly because FMRP is just a big mother protein that controls a lot, and it's even thought that some individuals with autism, in looking at their brains, they can have lowered levels of FMRP. So that may be dysregulated in autism in general, at least some of the data suggests that. So it's probably likely that a targeted treatment for Fragile X will also help autism. We're seeing that with our Baclofen. I think we'll see that with an mGlu-R5 antagonist. And I think some of the minocycline data, there's some patients with autism that are helped and maybe others that aren't, but I haven't seen the results of the NIH study. But also, in carriers with Fragile X, some of them can have some difficulties with aging, particularly the male carriers with tremor and balance problems and neurodegenerative symptoms. And so we're studying the association between that Fragile X associated tremor ataxia syndrome, how it relates to Parkinson's disease, and how it relates to Alzheimer's disease. And there's very similar kind of mitochondrial problems that happen in all three. So we're studying neurodegeneration in aging carriers in addition to doing the targeted treatments. And we're very interested in allopregnanolone, a medication similar to ganaxolone for treatment of FAXTAS, this aging problem. And also there's some evidence that mGlu-R5 antagonists are helpful for Parkinson's disease. So we want to try those mGlu-R5 antagonists in FAXTAS also. So it's a matter of talking the drug companies into doing this. But we're working on it. So there's a lot of similarities. I mean, that's one of the things that we're finding across neurodevelopmental disorders, a lot of biochemical similarities.
So I just picked two of the studies that have recently come out from the CHARGE study, and really I think we've been doing this long enough, and Irva Hertz-Pachota, who's the PI on the CHARGE study, has always told us we need to have big numbers, and we really need to have, if we're going to look at gene-environment interactions as a way of helping us understand not only autism but other developmental disabilities, we have to have big numbers. So when we look at our sample of children with autism, children with developmental delay without autism, and then typically developing children, we really do, we are beginning to reach a sort of this critical number where we can begin to look at very complicated interactions between genetic susceptibility and potential environmental triggers that increase or provide protective factors related to autism. So this is just to review the goals of the CHART study, and it really was to look at the potential role of environmental exposures to help us understand why the prevalence and the incidence of autism spectrum disorder seems to be rising so rapidly in what we think is a very highly genetic but complicated, complex genetic disorder, and trying to look at the interactions between those two. And over the years, we've really sort of narrowed our focus in terms of looking at immunologic dysregulation in children on the autism spectrum, more genetic and genomic changes, metabolic, and also looking at phenotypic variations to try and understand both etiology and potentially prevention and treatment. So I'm just going to highlight two of our studies that have come out fairly recently that I think have a lot of translational components in terms of how we might be able to really use this fairly quickly to reduce, hopefully reduce risk or understand risk for families who may have children with autism or who may want to alter their risk for having children with autism. So this one just came out, and this is really, I think, an amazing example of looking at gene-environment interactions, and something that is relatively common, and I think also has a lot of potential for treatment. So one of the things that we were interested in looking at is there are many studies that have suggested there's altered vitamin B metabolism and methylation in children on the autism spectrum, and that they may have altered metabolism for methylation, and that folate, or one of the B vitamins, is really important not only for DNA synthesis, but also for neuronal repair and methylation in terms of metabolism in cells. We know that supplementing folate in prenatal diets and in mothers who are pregnant has significantly reduced the rates of neurotube disorders. And so the recommendation has been that mothers who are thinking about getting pregnant or women who are thinking about getting pregnant and or who are pregnant should be taking prenatal vitamins, which have very much higher levels of folate. So we know that it changes the incidence of neural tube defects. But what we were interested in looking at, is there an association between autism risk and folate preconception and during pregnancy? You can see in this study, and this was a retrospective study asking mothers to remember many things in their prenatal and preconception environment, including whether they use prenatal vitamins or not. Blue are children with autism, green, typical development. And this is retrospective. We already knew that these children were in these groups. So we asked mothers to remember when they started taking prenatal vitamins. And you can see that for mothers that were taking prenatal vitamins prior to conception, this is 3 months before conception, and then this is at the time of conception, and this is at the time of delivery. So more mothers who had typically developing children started taking prenatal vitamins prior to pregnancy and in the first month of pregnancy, and looks like it had a significant protective factor in terms of autism risk. By the time we get out to the second month of pregnancy, most women, almost 90%, second and third month, are taking prenatal vitamins. So again, seeing differences here is very hard because most women are taking folate. So it looks like this early period in terms of pregnancy is very important in terms of reducing risk. However, the other thing that we wanted to look at was whether, and here's the odds ratios. I knew I was missing something. So you can see it's really the first 3 months before conception, the first couple of months of pregnancy. But then we also wanted to look at whether there were gene interactions, gene-environment interactions between the genes that we know that help regulate the folate, methionine, and methylation pathways, which are really important for cell energy and cell health. So what we found when we looked at both mothers and children in both of our groups, that we found that there were some gene variations, polymorphisms in the genes, many of the genes that are in this pathway. And the ones that are circled in green are maternal genes that we found differences that were correlated with autism risk, particularly when mothers were taking folate or not taking folate early on. And then this gene over here, the COMP gene, which is in purple or pink, is a gene that we found in children seemed also to regulate autism risk, particularly in relationship to their mother's folate use during pregnancy. So this is just an example of showing you what our results were. And so if you look at each of these genes and their polymorphisms, these are the more active forms, and these are the less active forms in terms of metabolizing genes. And you can see the difference between autism risk, whether or not mother was taking prenatal vitamins or not taking prenatal vitamins, and how these gene-environment interactions significantly increase the risk for having a child with autism. So this is an odds ratio of 4.5, 2.6, 1.6, 1.7, and 1.9. So these are very significant differences, and I think illustrate both genetic susceptibility in the face of environmental protective factor, which is folate, or without folate. And this is the example looking at a genetic polymorphism in the child itself and whether or not early on in gestation this child had exposure to folate or no folate early on. And again, this is a very significant difference, which indicates that the maternal environment during pregnancy and early fetal development for some children who are genetically susceptible may have a very important protective role for autism risk. So again, it's something that we think is important for mothers who are thinking about getting pregnant to understand, particularly families who may have family members with autism and who are really feeling that they are at increase for having a child with autism. So I think the most important findings are that periconceptual, so really before birth, prenatal vitamins has a potential for reducing risk for autism, especially in mothers and children who are genetically susceptible. And I think this is really one of the first studies to suggest a way that mothers may actually be able to take a preventative or positive action in terms of reducing their risk. So we will continue to study this, and I think it's very encouraging for at least a subgroup of children on the autism spectrum and their families. So now I'm going to shift gears, and you can see a lot of the same people are on this study as well. And this was a study, again, looking at the maternal environment. So this is looking at another set of risk factors related to maternal metabolic conditions and their risk for not only autism but other neurodevelopmental disorders, developmental delays without autism. This is a paper that's in Press in Pediatrics. And what we looked at in this study is we looked at prenatal records. So these were all mothers, again, who were in the CHARGE study that we knew they had either children with typical development or children with autism or children with developmental delays without autism. We went back and abstracted their medical records during pregnancy to see whether or not they had any of the conditions that we felt might increase risk for autism because they altered the maternal environment, such as diabetes, hypertension, obesity. These are all associated with dysregulation in the immune system. And a subset of one of our areas that we are doing more and more research is really looking at how the immune system and the nervous system in early brain development interact with each other. So anything that dysregulates the immune system, either maternally or in the child, has the potential for dysregulating early brain development. So you can see here that the numbers that are in red are significant odds ratios or suggest that there is increased risk for either autism or developmental delay compared to children with typical development. So what we found is that there was an increased risk in mothers who had type 2 or gestational diabetes during pregnancy to have a child with a developmental delay. There wasn't really any significant risk in terms of autism. But when we got down to looking at hypertension during pregnancy, increased risk for both ASD or DD, obesity, the same, increased risk for both cases versus controls. And then when we combined them, we found that women who had a combination of 2 or more of these had significantly increased rates of either a child with autism or a child with a developmental disability. And this is when we controlled for the mother's age at delivery, the kinds of things that we could rate ethnicity, education, whether they were on public or private insurance, the time of the year, as best we could for things that might also impact developmental outcomes. So those are the 2 studies that I think at this point really helps us to begin to look at gene-environment interactions and to begin to think about how we might develop some preventative kinds of intervention strategies for autism risk. Done? Thank you.
So why hypertension over, so you showed the slide that hypertension had quite a strong effect there with regards to causing elevated risk in autism spectrum disorder and developmental delay. Why, what's the theory behind that and not diabetes?
And not diabetes? Well, I think when you look at them together, it's additive risk. So I think hypertension it's in and of itself adds risk. But when you combine it with diabetes or with obesity, and they frequently do go together, then you have just accumulated risk. So why hypertension by itself increases risk? It's we think it's related to its effect on the maternal immune system and regulation.
Robin, why do women need more folate? What aren't women eating that they should be eating that would have provided the folate? I mean, has evolution somehow steered us wrong, or is it something that's changed in our diet?
Well, so actually one of the theories and one of the reasons we got interested in folate was that there was a hypothesis that because there's folate supplementation in cereals and lots of grains and breads, that maybe folate actually was contributing to the increased incidence of autism. So, it was a theory, and it had some plausibility to it. But I think that when we looked at it, we found it was just exactly the opposite. So I think part of what happens is when foods get over processed is you lose a lot of the vitamins. So you lose folate, and so we've over-processed them, and then we have to add it back. It's like, adding fiber back to things that should have fiber in the first place, but we've just taken it all out. Then we add it back.
Yeah, I think the gene environment, like you asked, so have we evolutionarily, what's happened is our diet. I don't think our diet has gotten worse, and the reason we recommend that women preconception start taking those vitamins is because the amount that actually protects, for example, against the neural tube defects, which is what the current public health recommendations are based on, is actually much higher than you would get from, even a pretty enriched diet. And even with the fortification, it appears that there is some, and of course it's not everybody. I mean, neural tube defects, even if they're most common, were maybe 1% or so, 1 or 1.5% to 2% perhaps. So, the genetics is also part of it because, many people have the polymorphism of the genes that, maybe they don't need as much, but maybe there is this small subset in the population that has, like, the children with the COMT, and you have the 7.2-fold, if they don't get enough folate because of their genetic, risk factor. So, yeah, I think the evolution is that probably most of us have the good genes, but, there's enough of the not-so-good genes, and combine that with not getting enough nutrition.
And, it may be that because there's there's more folate in most people's diet, even if they're not taking extra folate, there's no evolutionary disadvantage to having those polymorphisms anymore.
Okay, most people know something about ADHD because it's the most common childhood psychiatric disorder, and we now know it's one of the most common adult disorders as well. But I still think the statistics are somewhat staggering, how common, 3 to 5% at least. So in California alone, we have a lot of people running around with ADHD. Children with ADHD, their symptoms oftentimes come out in the classroom. They can be ostracized. Parents tell me they had their children asked to leave the classroom. They have them looking for other schools that will accept them. They have poor social relationships. But it's in their adolescence and young adulthood where some of their choices become very concerning to parents. And so, riskier sexual behavior, they have more sexually transmitted diseases, they're more likely to have a child at a younger age, lots of issues with substance abuse, higher rate of traffic accidents and traffic citations. So they're not just a menace to themselves, but on the road, they're a menace to all of us, is one way of thinking about it. They have much higher rates of unemployment and underemployment, so they actually earn less money for the same jobs that other people might be doing. And that's probably because they switch jobs more frequently, but also they may be very bright and very talented, but they're more prone to making careless mistakes. So that eventually has a cumulative effect. And so the common symptoms are problems maintaining attention. Hyperactivity, we see that primarily in the younger people, and impulsivity. And I'm particularly interested in impulsivity, and we'll talk about that. Now, you don't need to have all those symptoms. You can just be inattentive and what we call hypoactive, kind of daydreamy, where you sit maybe in the back in the room and you're not really paying attention, but you're not running around or impulsive. And that also is a type of ADHD. That's what we call the inattentive type. There's a huge burden in the classroom at the college level, if they make it to college, as well as in the lower grades. They repeat grades more often. They need tutoring. And we recently published a study with Josh Breslaw as the first author that found 1/3 of kids with ADHD are not likely to graduate from high school on time. And that's a staggering amount when you think about how many people have ADHD and they're not graduating. And as I said earlier, a lot of these people are bright, but they don't have the skills and organizational ability to make it through. And they have affected social relationships. So their partners, their coworkers, their friendships at the child level as well as the adult level. So decision-making, impulsivity, that's an area I'm particularly interested in. And I'm interested in this tug of war between what some people say good versus evil, or now versus later, meaning I want it now, but I know that I need to wait for the better stuff later. And for kids, texting versus homework, right? I mean, is that not a common theme that we hear? And for me, it's chocolate versus fruit. I actually like both, but if I see chocolate and I think the chocolate might be gone, I'm going to go for that chocolate first to make sure I get it, which we now know is tied to some brain regions here. So this is actually from a colleague of mine, Sam McClure. And it turns out these brain regions, the orbital frontal cortex and the nucleus accumbens, are what make us say, go for the chocolate, or do the texting, or answer the cell phone even though you're driving, and you shouldn't be answering the cell phone. Whereas these part of the brain, the prefrontal cortex and the parietal lobe says, if you go for the chocolate cake, you're going to have to be jogging a lot tomorrow. You better think about it. So this is this tug between here, and our theory is that certain people have more of these issues where these regions aren't working as well as they should be, whereas for some people, it's these areas of the brain that are not optimally working. And in the long run, we hope that we can have some sort of diagnostic way of understanding where the hit is for individual people, and then have treatments designed based on that. But we also think this is affected by development. And this is the same brain regions you saw on the slide before. And this is with adults, healthy adults, making choices. But this is our schema, our model of what we think happens. And this isn't typical development, but we think is heightened in ADHD. And this is what we're studying in our lab a lot right now. And so as you mature, your prefrontal cortex, which is what we call the executive center of your brain, comes under better control. Is that any surprise to any parent, right? Do you give the keys to your car to a 16-year-old and worry the same as you would with a 25-year-old? No. And that's because these executive centers of the brain are coming on and helping with thought decision-making. What we now know is that area of the brain that says go for the cake, the ventral striatum, in adolescence, it actually becomes overactive. So when you're younger, it isn't even as active as it will be when you're an adolescent. And ADHD, it looks like that's even heightened. So we've got this tug between these regions and these regions. And eventually in your 30s, if you're ADHD, things start maybe for some people coming around, but certainly not always. And this is just an example from our lab. We have some simple ways of testing it. We don't have chocolate cake around because I think we would all be eating it. So instead, we just ask people, would you prefer $55 today or $75 in 61 days? And we do with a series of questions, and it's actually incredibly predictive. And HC is healthy control, and this is a Mac versus PC issue right here, but that just shows level of impulsivity here, and this is age. And the ADHD people you can see are much more impulsive, but the impulsivity, some of it declines with age. Whereas in general, the healthy control are less impulsive, but also you see a decline in impulsivity. That's not to say that people in their 60s with ADHD don't still have problems with ADHD. We've recently seen that in the clinic. So this is another way we're looking at this tug of war, is that we know cognitively people with ADHD, one of the areas of difficulty that they suffer the most from is working memory, the ability to recall information and process it online. So if you get a phone number, you don't have a piece of paper and a pen, you rehearse it. And that's when you're using your working memory. And we find that people with ADHD are not using these frontal regions when they're doing working memory, but those are the same regions that are involved when you should be making decisions about planning and your choices, what you do. But we find these other regions are overactive when they're doing cognitive tasks even. And so this is, I think, also reflective of what we see when parents say, the kids look like they're working so hard when they're studying and trying to do their homework, and they're exhausted after, but they're not getting anywhere. And this suggests they actually are using their brain, they're working really hard, but they're not using it efficiently, because this is overactivity in regions of the brain that are not really important for some of these cognitive tests and not predicted in working memory. These are visual motor areas of the brain and emotion and so forth that tend to be more active. And so we're also interested, as I started out talking about how academic issues are so prominent in this disorder, that we started looking at the relationship between brain functioning and how people did on academic tasks as well. And what we found is that the more people were using those brain regions that are involved in motor and reward response, such as the caudate, it turns out those are the ones who also had the worst math skills. And then we did a similar test where we looked at self-control directly and correlated with math performance, and they're highly correlated. And again, it turns out those who are people who are most impulsive, one area that they get a huge hit in is their ability to do math. And so, to me, that suggested maybe one thing we could look at is think about an alternative way of looking at treatments. If you actually, instead of just working directly on the dopamine system, which is what we use with medication like Ritalin, what if you do something like you do some cognitive training as well, where you teach people to maybe think about the values of your making decisions between now and later? Will that make a difference? For young people, probably not. But if you did something like essentially using some sort of math training, but also had it with real life expectations and what that would do, might that not be an avenue we haven't pursued before? So targeted treatments, I think everybody here is interested in developing those. And this isn't what I talked about today, but we've done a lot of work on subtypes, because no child with ADHD or adult is like the person next to them with ADHD. They vary dramatically, and we think treatments might be very different based on their subtype profile. And that's some of what we're looking here as well. And just in terms of our clinical services, I thought I'd talk a little bit about that, because we have a very robust clinic. We have psychiatrist, Dr. Kiadi Bramba, and Dr. Murat Pakurak works in our clinic, two child psychiatrists who work with children and adults with ADHD. Myself, I'm a clinical psychologist, and Dr. Faye Dixon, another clinical psychologist. And we have a number of associates. We have child psychiatry fellows, people in training, learning about the disorder, as well as developmental and behavioral pediatric fellows. And we do evaluations for children and adults with ADHD, and that includes general evaluations as well as medication evaluations, where we try to help determine whether somebody be appropriate for medication or not. We also offer some treatment services. So we have ongoing parent education classes, typically for parents of children between 6 to 12 or 6 to 14 years of age. I just started doing an adolescent homework organizational success group, and I have lots of parents who want their children to be in a group, but I don't think a lot of kids really want to be in the group. So it's been interesting. So I think we're going to next focus on doing some adult groups to see if we can help them with organizational skills. Thank you very much. And this is my team.
Could you talk a little bit about age differences in response to Ritalin and other sorts of treatments, if there are any age differences?
That's a great question. Actually, Ritalin, sure. So is there a difference in terms of response to treatments according to age? And for the most part, the treatments that are most commonly used are the stimulants like Ritalin and Adderall and so forth. There's response from preschool age all the way up through senior citizens. They just released recently, but it's been over the past few years, several studies from the preschool study in ADHD, and Dr. Hansen might even talk some about this too, about how the American Academy of Pediatrics recently released some guidelines about using stimulants for preschool age kids. So they work, and they have fewer side effects, and they work better than some of the other treatments for ADHD that are out there. What I get concerned about with the senior citizens is that oftentimes by that age there's a lot of comorbidity. So they have diabetes, they have cardiac problems. And so that's something that we see in ADHD as people mature. They have a much higher rate of these physical problems, which might be related to the ADHD. There's certainly some suggestion. But that starts limiting what medications you can use for that population.
My question is, I know that I don't know if there's any similarities or ties, but does folic acid, I know taking it while you were pregnant decreases, it showed the result, excuse me, I'm a little nervous, showed the results in the other presentation prior to this one. Has there been any studies of any type of vitamins or anything that can be taken during pregnancy to lower the risk of ADHD?
Wow, what a great question, Irva, right? So we've been spending the last week intensely working on a grant application in autism, but looking at ADHD symptoms, and specifically that was those were some of the analyses that we were looking at, because it turns out, at least in the charged population, that there's a much, much higher rate of ADHD symptoms than there is in the typically developing population. And so we started looking at that literature, and please correct me if I'm misquoting this, but it seems to be that there is a relationship, is what I'm remembering, is that I can't remember specifically if I know the phthalates increased rates of attentional problems, and I can't remember if the folic acid seemed to reduce. It was so much information so quickly.
So there are some studies that suggest, that folate during pregnancy reduces behavior problems in really young kids, so maybe modulates behavior regulation, and then as kids get older, that they have a little bit better academic outcomes and also less attention problems. So.
And I think there also just behavioral regulation, like you were saying, I think also some relationship to maybe soft sort of psychiatric sorts of mood and so forth. So, yeah.
Hi, I'm just taking a speech pathology classes at Sac State, and we were talking about Adhd and Tv exposure. And was that considered in the study? Like a lot when they were a toddler and it being the babysitter?
TV, you mean television. I was thinking tuberculosis. Okay, got it. Not TV. TV. Okay. So there were a couple of studies looking at that, and I don't know what to think of those. The original study that came out a few years ago just showed a correlation between amount of TV watching and rates of hyperactivity. And from my clinical experience, I know there are a lot of really tired parents who park their kid in front of the TV because they need a break. So I don't know which direction that's going in, and that's always been my concern about those studies, is that that happens. And I certainly have met with plenty of parents where there's a television in the child's bedroom. And that's one of the first, and they have sleep problems. And I say, well, think about taking the TV out. So I'm not sure which direction it goes in, so I know, but that's immediately, that was my question. Was it not that they were also using the TV as a sitter at times to get a break? If these kids are more physically active, they might be more likely to need that. So I don't think we know for sure.
There are some studies that suggest that the more television kids watch early on, the more difficulty they have with attention and just activity regulation in structured situations. So.
You know, the problem is TV and the commercials are so impulsively driven, but also an alternative activity would be reading, which requires more sustained attention and more perseverance. So that would be less likely for a child with ADHD to read for longer periods of time and be more likely to watch TV and something that kind of reinforces, you know, impulsive changes in scenes, et cetera. So
definitely, we always say a treatment for ADHD is, in the old days we used to say it was Nintendo. Now maybe it's Angry Birds now, because they can sit there and do that for hours, but it's this high rate of stimulation that's extremely salient, and that's what people with ADHD need in terms of environmental therapy sometimes.
So yes, let me tell you about this disorder with a very complicated name. The reason it has this name is it used to have lots of other names: velocardiofacial syndrome, DeGeorge syndrome. These are frequently used, and you may have heard these names, particularly some of you in the medical profession. But there is a deletion on chromosome 22 on the long arm, the Q arm at 11.2. And this disorder is at least 1 in 4,000 live births in terms of its prevalence, which is about exactly the same as Fragile X syndrome. And we actually think it may be yet more common than this. The major manifestations are very variable and very many. Not everyone has all or most of these, but many heart defects and cleft palates, facial dysmorphisms, autoimmune disorders. So the nice thing about going last is I can refer back to a lot of what everybody said, how the immune system can change brain development, anomalous brain development, lots of things in the midline, the body and the brain. And of course, elevated ADHD in childhood, as is so often in these disorders, and in schizophrenia in adulthood. And this is an extraordinary risk because it's about 1 in 100 in the typical population and about 25 to 30% higher, 30 times higher. So 25 to 30% of these individuals have risk of that kind of psychosis. And anxiety and specific phobias are very common in both children and adults. There's been a lot of controversy over autism spectrum disorders. Estimates from 20 to 50% are based on our clinical assessments. We think it's actually fewer than 5%, but there really is definitely social impairment. We think that comes more from the anxiety issues. So this is a really interesting story of how bringing a basic neuroscience project to the Mind Institute, where real clinical work goes on, and having these wonderful clinical colleagues that I have, has completely changed the face of our research. And so it's led us to understand these kids completely differently as a result of the clinical work that's been going on. And we now have this working hypothesis of sort of 3 pieces: that these children have cognitive impairments, and of course that limits their competence in multiple ways. I'm going to show you some specific examples in a moment. Thinking about spatial and temporal information from less accurate mental representations impairs their development in things like space and time and number, which makes school rather difficult. And also executive function limits, and I actually dropped my impulsivity slides, but I might be able to squeeze them back in at the end, we'll see. But that makes it very hard for them to organize their resources and use their cognition effectively in the way that Julie was just talking about. Now, there's no directionality implied here. These all modulate one another. But having impaired cognition, which is often measured in borderline IQ, creates and interacts with increased stress and anxiety, and further modulates and challenges development. So we had this question about, being happy and what the environment was. When you're stressed and you're anxious, it's very hard to focus and to do good work. And when you're struggling, you may get more stressed and anxious. So these things modulate one another. And we found that anxiety impairs attention. So it increases inattention, sort of in the way that Julie was just talking about, and impairs executive function. So there's that struggle that she was just talking about. So this is a very common kind of story. But we've also found that family and school and community supports further modulate this interaction and have led us to think about these kids on a kind of a coper, struggler spectrum. And so how well they're supported at home and at school and the environment actually changes this considerably. So the strugglers experience what's called higher allostatic load, that the struggle of keeping up imposes a biobehavioral load on them, and we hypothesize, because this is not the truth, this is our hypothesis, may increase the schizophrenic risk, the risk for schizophrenia. So this is what's called an integrative stress diathesis model. That's a psychological theory that explains behavior as a result of both biological, genetic example, variability, and the stress from daily life. And so this gives us some very tractable targets for intervention, because things like anxiety and the environment and supports can be really changed. And we're actually seeing that happens. So let me just show you some examples of what kinds of, I'll give you one example of a kind of impairment, and just get you to see what this might be like. So we're very interested in spatial information processing, because it does relate to numbers and math, which are very hard for these kids. And so we have a test that looks at the mental representation of and the ability to compare quantitative information. And we look at the specificity or the generality of this by using quantitative information and also sound, pitch information to see whether it's the specific information that's being represented or the ability to compare information. And this is based on the notion of crowding. Well, what is crowding? It's hard to explain, so I'm going to show you, okay? So this is my audience participation part. There's going to be a white screen come up here, and there's going to be a cross on this side. And I want you to fix your eyes on the cross on that side and don't move it, okay? You ready? Here we go. Look at the cross. Now, without moving your eyes, tell me how many bars there are on the other side of the screen. Yell out. 5. Oh, some real disagreement here. Okay, go take a look. Okay, so what happened was I forced you into a situation where your attention is locked down here, and these are very, very similar. They're identical items and are identically spaced, and they crowd because they don't stand out from one another. So it's very hard to actually get a handle on how many things there really are. So that's what crowding is like, and if that's affecting all of your mental representations, it might affect your ability to think about space and time and numbers. So what actually happens? We show these kids in our experiments situations like the one I'm going to show you now, where you have 2 bars, and you have to say which is the longer of the 2, and then we also do exactly the same thing with ratios with auditory pitch, which is the higher of the 2. Okay, and all of our data comes from 7 to 15-year-olds. Hopefully this will work. So which of these 2 is longer? Blue bars. The first. That's really easy, right? Okay, and now again, which one of the 2 is longer? Just the blue bars. Yeah, so very difficult. So actually, the first one was 50% of the other one was 93% of the second one, so it's actually pretty hard to tell. And when we do this, we found that the kids with 22q deletion can do pretty well if it's 50% up to about 87%. The smaller one is about 80% of the bigger one. But the typical kids can get all the way up to about 93%, which was the second thing that you saw. Most of them can do that before they get into chance behavior. So there's a significant difference of how much of a difference they need before they can tell the difference. When we ask them to do this with pitch in the same way, there's absolutely no difference at all. So it's not the ability to compare information, it's the ability of representing that information. So that makes it hard for them to think about quantities and hard to learn about a lot of different things. That difficulty, if you have an IQ of 75 like most of these kids have, it's like being a 7.5-year-old in a 10-year-old's world if you're actually 10. That can create a lot of stress and anxiety. When we measure stress, this is Elliot Beaton's work, we find that there's very elevated measures of anxiety, some of them clinically elevated, which would be up in these higher ranges, but very different, higher levels of anxiety in a range of different measures in the kids with the deletion. So they're experiencing a lot of anxiety. So the question then is, how does that increased anxiety affect their ability to actually function? Well, what we found, this is Kathy Angustieri's work in my lab, that there's no relationship between their IQ, which can go really from 55 all the way up to 100 in some kids, and their adaptive function. And what does adaptive function mean? It basically means being able to solve age-appropriate tasks or problems like getting your way around, having your books of the right class in school, and other kind of things like that. So usually you find this as a strong relationship, but in this population we don't see that relationship. What we do see, however, is that there's a very strong negative relationship with anxiety. So the higher the anxiety, the lower the adaptive skills are. So there's a great deal of anxiety here, and the higher it is, the harder they're having time functioning. And this really seems to be related to the executive function parts of things, which, as I said, I moved out to the end so I wouldn't take up too much time. So this gives us, and both Elliot and Kathy have shown that not only is adaptive function related to anxiety levels, but also to biological measures like cortisol, which is stress hormone production, and potentially modulated by the risk factors for later psychiatric disorders. So Joel Stuttered, who is a psychiatrist who just moved from my lab to the National Institute of Mental Health, came up with this lovely picture of how we think now and how we used to think. So with the 22q deletion population, we used to think really that there was a large group with no disorders and a small group but still a rather large group compared to typical population, who would end up with a psychotic disorder with overlapping anxiety and mood disorders. And this was just something that was a risk that was going to happen. But now we tend to think in this way, that there's a bunch of people with no symptoms and a bunch of people at risk, and that you can move people backwards and forwards between symptoms and risk and disorder and so on and so forth by modulating these risks and changing the environment. And so there's lots of very well-known risk factors, some of them biological and some of them cognitive, as I talked about before, and things like substance abuse, which can really be a big risk factor. Of course, if you have ADHD, you're at higher risk for that kind of stuff, so you see how this all links together. But use of SSRIs that was just talked about by almost everybody, atypical antipsychotics that Randi talked about, cognitive behavioral therapy, teaching people to learn how to respond to stressful and anxiety-provoking situations, and good nutrition, things like omega-3 fatty acids, have all been well-validated responses that reduce the risk and potentially move people back. And so there is a notion of what's called a prodrome, which is a measuring people who are at risk for a psychotic disorder but don't have it yet. And we find, and may not get it, there's about a 50% chance of developing. We found that about 50%, and so have others, have that prodromal profile, but only about half of those people will actually convert. So there must be a lot of protective factors as well as risk factors. So what we found in our clinic, the great clinicians that work with me, Ingrid Lecklater and Janice Enriquez and these other clinicians, that we've really found these kids organizing themselves into these two groups. And just to finish up, I'll give you a couple of examples. So these are case composites, they aren't actual kids, but they represent pretty well what we see. So a Coper, this was a child who has borderline IQ. Actually, 63 would be considered in the mild mental retardation range, as the term used to be used, intellectual disability, and really not doing that great in terms of intellectual disability. But his adaptive scores are relatively high, particularly in things like social adaptive and conceptual reasonably well. But the most interesting thing was that the parents rated him, I think it was a him or her, rated this child as having very low levels of anxiety. And we heard things like, the child is very integrated, it's a her, into her community, well-liked, has a positive sense of self-esteem, has good rote learning skills that support development of basic academics, okay? So this is a child who's actually not very well endowed intellectually and struggling, but actually is relatively low in anxiety and relatively good in adaptive function and has good strategies and is doing really quite well, really above her expected intellectual capabilities. By contrast, a struggler, you see a child with really quite high IQ, typical range IQ, which is unusual for this population, and relatively similar adaptive scores to the coping child, but all of the parent ratings and the child's ratings, except for fear of physical injury, were clinically at risk or significantly high. And this child was described as being anxious, having low self-esteem, being viewed as others as inattentive and disorganized, just as Julie was talking about, oppositional, so when you get frustrated, some people act out in that way, and engaging in risky behaviors, classic sort of ADHD-like profile. And we think that ADHD profile is generated by this high level of arousal. Okay? So the point is you have these two different profiles, and it's not a factor of how smart you are, it's a factor of a lot of how you're coping with your environment and how the environment can be changed around you to modulate those risks. So some of the things that we know that are very well validated, things like cognitive behavioral therapy, we often talk about Camp Copilot, and Coping Cat is a very well validated tool that's used with a therapist. It has a relatively high linguistic and conceptual load, so in kids who can't do that, we talk about biofeedback or meditation or exercise, and you can really do this with any good clinician. The wonderful thing about this is you don't need a 22Q expert. All around people are those kinds of clinicians who can help them. So there's immediate things that can be done. And then sometimes we need to include something like an SSRI that's been talked about to reduce some of the biological responses, and sometimes ADHD medications, which have some concerns but are still relatively safe. But here we recommend that the parents work with a pediatrician or a psychiatrist. So the point is that we can immediately think about well-validated things that actually change the quality of life on a kind of a minute-by-minute, hour-by-hour basis, and changing expectations, changing school, changing environment, can really reduce the stress and anxiety and sometimes improve function considerably. So what's really happened here is this clinical work has driven a real integration towards translating our basic research into these very productive kinds of recommendations we can give the families. We think that there's several pieces here, that there are basic representational limitations that make learning difficult and create this allostatic load of the neurobiological stress that's interacting and relating to the ability to cope. And that creates executive function impairments, but we can change things to intervene in certain ways to make the targets of functioning more realistic and reduce that stress. This is a very rare and interesting model for protective studies of longitudinal atypical neurocognitive development and risk for psychosis, because it's the third highest genetic factor. The first two you can't really do longitudinal studies of. So looking at these interacting biological and cognitive and environmental changes really actually may be a way of exploring how to understand and sort of pre-identify risk for psychosis and maybe actually ward it off long before it actually happens. And we're actually planning a grant just on that next year. So these are the people that actually did all the work I just talked about, and that's it for me. Thank you.
I just wanted to just add something that maybe you could talk to a little bit more, Tony, too. Is we have some very interesting, a little bit troubling, but also very interesting, scientifically interesting data showing that there's a subset of children that we're seeing in 22Q that have a high degree of anhedonic depression. And maybe you could comment a little bit more on that.
Yeah, so I dropped about 3 slides to try to keep underneath us, so thank you for getting that one back in. So actually, Elliot's been measuring measures of depression, and it's really very surprising that children this young, particularly with a developmental delay, would show depression at all really in significant measures. And there is, as you can see on this slide, there's higher levels of total depression, but the one particular subscale that shows up is anhedonia, or the lack of the ability to experience pleasure. Some people call this the Eeyore syndrome, if you know Winnie the Pooh. But that is actually a critical identification of the prodrome for psychosis, when people kind of back away from society and show the inability to get pleasure from things, don't take care, for example, then later of their personal appearance and self-grooming and those kind of things. So this is potentially worrying. And so what we want to try to do is try to subgroup these kids into different types, the copers and the struggles, but also different biological factors, genetic and brain changes, and these kinds of clinical measures, and see if we can understand how to move them backwards and forwards along that trajectory.
Dr. Simon, it is clinical lore that individuals with intellectual disability is more likely than general population to suffer from mental illness, including anxiety. Would you say that what you just said about 22Q is generally applicable to most individuals with intellectual disability?
So I think you were saying that people with intellectual disabilities are at higher risk for psychotic disorders. Yeah, psychological disorders. Yes, that's absolutely true. Having an intellectual disability actually does increase the risk. But I think what's very interesting here is that 22Q genetics are not destiny. And what's very interesting about the situation that we've seen is that the Coper kids are very often outperforming their own intellectual capabilities actually in the real world. So a particular child I'm thinking of, like the Coper I showed you, may have an IQ of 65 and not very good scores across those subscales, but actually had high adaptive scores, and actually one child I often think of had math and reading skills in the low 90s. So that's a child who's basically outperforming himself almost by 2 standard deviations. So I think the point is that there's sort of a risk factor there, but you can do a lot here to change it. And so even though you measure low, if you're functioning high, that's probably one of the protective factors on that.
So it seems like self-esteem is a big part of this, the Coper
Yeah.
thing. So is that an area of intervention on,
Well,
I would assume that
yeah,
the
it
family
really is.
dynamic would have a lot to do with that.
Yeah, so the way I often describe this when I talk to parents is to use optimum stimulation curve. And when you're going up the optimum stimulation curve, the more you're getting stimulated, the more activity you're engaging, and you tend to experience mastery and pleasure and positive motivation and self-esteem. You get very quickly over the top and you start heading downhill, then you think, I'm not good at this, I can't do this, I don't want to do this, and you feel bad about yourself. So I'm not sure that you can directly intervene with self-esteem per se. I mean, there may be ways, and maybe Ingrid has thoughts about that, but I think the inverse of that is that reducing their anxiety, improving their function, reducing stress, and other kind of things like that enables them to function better, and self-esteem probably follows from there. But also finding things that they're good at and concentrating on those kind of things. We often talk to the parents about that. So it's definitely a target. Whether you can go just at that alone, I'm not sure.
This is a question for Robin. Have any of the findings you found in the CHART study been replicated in the infant sibling study? For instance, the folate and the maternal illnesses?
So we haven't yet had enough numbers of kids who have a final diagnosis to know whether or not we'll find the same things, but we will definitely look for that. Our numbers are so different, but it's a really good question, and I think this study needs replication because the best way to do replicate a retrospective study where we ask mothers to remember what they ate, what they were exposed to, when did they start taking vitamins, is to do it longitudinally. So that's what we're trying to do now.
Hi there, I'm a school-based speech pathologist, and over the years I've had a number of students who've had these various types of issues. One of the things that has always been interesting to me is the idea of multiple births. And I have a number of students over the years who one or more of, either if it's a dyad, then it would be one of the twins, or if it's a triplet, one of them has autistic characteristics, and there might be some comorbidity. Is there any current research that is looking at the role of multiple births, potentially with folates, where they are splitting the mother's intake into more than one baby?
So there have been several studies that have looked at a variety of prenatal or perinatal risk factors. So multiple births is always considered a risk factor for a variety of developmental disorders or disabilities, including autism. So has preterm birth, and so if you are a twin or a triplet, you're more likely to be born preterm. So this is why a lot of these studies get so complicated by confounding variables. It might be that it's related to being a multiple, gestation. It might be that you're more likely to be born early, and that's really your risk factor. So it's really hard to sort those out. But when you look at all those risk factors together, it looks like they each maybe increase your risk for a variety of developmental disabilities.
Yeah, I just wanted to ask, do people that have ADHD, whether adult or children, have a higher increase of suicide?
Very interesting question. My colleague at UC Berkeley, Stephen Hinshaw, has recently published some studies showing that he's been following a group of girls for several years, and there is a much increased risk of suicide attempts. And so yes, those data are fairly recent that have come out.
You said that the immune system was, the dysregulated immune system had to do with increased risk of autism. So how come they say that the immunizations are not?
The vaccine question. Well, it's interesting because we have found, one of the things that's very clear is that autism is not caused by one gene or one thing. It's probably lots of different etiologies for autism. And what we're finding in the CHART study is that there is a subgroup of children who have what we're calling dysregulated immune systems. And it may be that they are kind of in a state of increased inflammatory processing, or also that they, in some cases, we have children who have low levels of reactivity to immune challenges. So we have a subgroup of kids with autism in the CHART study who, when we look at whether, if they've been vaccinated and we look at whether, how they responded to those vaccines, that many of their vaccines they're actually not responding to. It's not that they're over-responding, which was the original theory that might be related to, why vaccines might be related to autism risk, is that they're actually really not responding to vaccines in a way that if they probably should be revaccinated so that they have immunity to protect them from some of these vaccine-related illnesses. So we really worry sort of the opposite, that children who may have dysregulated immune systems and are under-responsive to immune challenges for their vaccines really maybe are particularly at risk for getting wild-type disease if they're not vaccinated. So, and I think what we're learning also is that the immune system has multiple different parts. It's not a static system. It's very responsive to the environment. So we have some kids who have what we call upregulated immune systems, some kids who have downregulated immune systems. We have some mothers who have immune systems that we think are dysregulated and may affect autism risk during pregnancy and may alter early brain development in the children, as well as dysregulate the children's immune system as well. But there have been lots and lots of studies trying to find an association or explain an association between vaccines and autism, and there is nothing that has been found in large groups of kids. So the only thing we can say is that for most kids, vaccines don't seem to be related to autism. What we can say is that for few small individual kids that there may be some relationship, but most of the time it just looks like there's no relationship, and that actually being vaccinated if you have an abnormal immune system is probably a good thing to do.
So I just wanted to clarify one point. Robin said there's no single genes associated with autism, but there are single genes, and in fact, the Fragile X mutation is the most common single gene associated with autism. But there are some other genes, neuroligands, neurorexin mutations, SHANK3, some other single genes that can be mutated and cause autism. So usually in the autism workup of a child, you definitely rule out Fragile X, and you look for other genetic abnormalities with microarrays and chromosome testing, and all of that is part of the medical workup for autism.
Question is for Dr. Hagerman. For the sertraline trial, are you seeing the language impairment because of the decreased anxiety in these young kids, or is there another mechanism that would be involved?
Well, so the language impairment comes from the Fragile X gene mutation itself. Yeah, but so the benefit, I actually think that really boosting serotonin levels in the front part of the brain, and Diana Chugani has shown that in the front part of the brain, serotonin levels can be low in idiopathic autism too. So boosting serotonin probably does several things. It definitely can improve anxiety, and in the patients that we've seen, we typically see improvements in some of the sensory integration problems and overreactivity to stimuli, et cetera. But there's also neurochemical changes that happen as you boost serotonin. BDNF increases, and there's some stimulation to connectivity in the brain. So for a variety of reasons, and there may be a direct effect in language areas of the brain, that language improves. So I think it would take some very carefully done functional MRI studies to look at activity in language areas on sertraline to actually prove that, whether there's a direct effect or not. But I think it's probably a variety of factors.
Hi, I had a question for Dr. Hansen about autism. I recently saw on the news as a story about a 16-year-old girl who had autism and was being treated for that. And what they found was that the mother had Lyme disease during pregnancy. And now the 16-year-old daughter, they thought, well, let's see if the daughter got some of the Lyme disease during the pregnancy. So they found she did have Lyme disease, was positive for that. They treated her with medication for Lyme's, and as they did that, the symptoms of autism decreased. And so they're wondering the correlation for that, and they're continuing studies on that. They didn't give much more information on the news spot, but wondered if you had a comment on that or any knowledge of such research.
Well, I think that this has been a question that comes up not very often, but there are pockets across the United States where there's a high incidence of Lyme disease, and it's a tick-borne illness, so where there's lots of deer with ticks that have Lyme disease. So Connecticut happens to be an area, and I can't remember where she was from, but one of the things that I think is really difficult is that if you are infected by a tick that carries Lyme disease, it's very hard sometimes to test for it, to know whether or not you have it. So infectious disease people will say it's very difficult at different times after you've been exposed to whether you actually have the disease or not. And the symptoms can vary. So, phenotypically or clinically, it can look like lots of different things. And so it's just hard diagnostically. And I think that the thought is that, and it's not clear that it gets passed on from mother to child during pregnancy, even if the mom's pregnant. So I think, again, there's not very good evidence, and there's sort of these isolated cases where there's sort of this suggestion, and I know that there are several physicians who believe that a lot of kids with autism actually have undiagnosed Lyme disease, and they're treating them as such without really very good diagnostic evidence that that's true.
But it could, it's possible that there could be an immune mechanism. So chronic Lyme disease can really crank up the immune system. And if there's a genetic predisposition to produce autoantibodies that could affect fetal brain development, there could be this an exacerbation of the immune dysregulation that could be related to autism.
But I had a question for Dr. Simon. I had to keep reminding myself that you're just talking about this subpopulation of the 22q deletion, because so much of what you said sounded like it would apply to almost anybody with those kind of learning challenges in that borderline range.
I think that's exactly right. Our evidence is based on this population, but the picture is much more general. I mean, I think that's very clear. In fact, many kids who have one of these disorders, they have specific phenotypic variations, but many of them have that common profile that we see. And so even kids without a known disorder, you're going to see that level. And in fact, there's some very good work happening from people like Danny Pine at the NIMH and others who just show very similar things where you've got primarily anxiety-driven disorders where you see very similar things to this. So I think you're exactly right. That's a very smart comment that this is a story that we've generated from this population, but what we're saying here applies very broadly, and I think that's the great thing about it, that they're very tractable interventions. The expertise is very broadly available in the community, and so these are things that can really be changed and can change the quality of life and the developmental trajectory pretty effectively and quickly, I think.
This is maybe directed to Dr. Schweitzer. Have you done studies with children who were like very newborn that had high rates of febrile seizures that developed the ADHD type of?
So I think it's true with any neurodevelopmental disorder. There's a higher rate of likelihood that you're going to develop one if you have febrile seizures, I imagine. Is that true? Or seizures? I don't know about febrile seizures, though.
Actually, in the Fragile X carriers, we've just recently published a study that it's really seizures that can really determine who, particularly males with the premutation, who would be likely to develop autism spectrum disorders. And if they have seizures, that's a very strong association to the development of autism spectrum disorders.
There's so many different things that people have found, and that's anything that's, as you said, prenatal care, delivery, health of the mother, and so people have, I was going to say tobacco, exactly. Yes, yes. That's the reason it's the most common childhood disorder. But there's definitely lots of evidence that there's a genetic component, a very strong genetic component as well.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.